So this is an anteroposterior erect chest radiograph of a skeletally mature patient. The first thing that really strikes me is the presence of bilateral, relatively symmetrical interstitial shadowing, which predominantly affects the upper and mid zones of both lungs. The shadowing isn't scattered. There are elongated opacities that stretch out in these zones, and each of them measures several centimeters in length. These opacities don't show cavitation, which is important to note because cavitation could lead us down a different diagnostic path. They're also not typical for simple pulmonary scarring, which rules out a few conditions we might otherwise consider. Now, as I'm scanning the right hilum, it does look a little bulky on this film, but before jumping to conclusions, I want to point out that the patient is rotated towards the right side. That kind of rotation could give the impression of a bulky hilum, so I'd hesitate to interpret that too heavily without other signs to support it. There's no evidence of convincing hilar calcification, which would be more suggestive of chronic infections like tuberculosis. All right, so if this patient has a history of occupational dust exposure, perhaps they were a miner or worked with ceramics, we need to consider silicosis or coal workers' pneumoconiosis. Both of these could account for the symmetrical upper zone fibrotic changes we're seeing here. Now, these mass-like lesions we're looking at could represent progressive massive fibrosis, or PMF, which is a complication of pneumoconiosis. But without any history of dust exposure, we'd need to start thinking about other causes of upper zone fibrosis. So what else could it be? Let's say there's no history of occupational exposure. In that case, we might consider an alternative diagnosis, something like sarcoidosis or perhaps ankylosing spondylitis, though the latter is less common. The symmetry here really pushes us toward dust-related causes, though, so it would be prudent to get a good occupational history. In fact, symmetrical upper zone fibrosis should make you think of a dust-related disease unless proven otherwise. Ankylosing spondylitis is one of the rare exceptions, but generally, dust exposure takes the lead in these cases. If the findings were asymmetrical, though, I'd start considering other things. I'd want to look for well-defined edges to the fibrotic changes and any accompanying bony changes, which might suggest the patient has had previous radiotherapy. Another thing to keep in mind is that hilar lymphadenopathy with eggshell calcification and upper zone fibrosis is very characteristic of silicosis. But we also see this pattern in conditions like sarcoidosis. What I'm not seeing here, though, is inactive tuberculosis, which typically doesn't present with hilar lymphadenopathy. The complication of silicosis we're seeing here, progressive massive fibrosis, is often bilateral, symmetrical, and takes the shape of these sausage-like masses that change very slowly over time. It's important to remember that silicosis is a predisposing factor for tuberculosis, so any pulmonary masses might not necessarily be benign, they could be infectious. And we also need to be on guard for coexisting malignancies, since silicosis increases the risk of lung cancer. If this were my patient, I definitely want to review any previous imaging to assess for change and to determine if we need to escalate to further imaging, like a CT scan, if the picture isn't clear. To sum up, these findings most likely represent silicosis with progressive massive fibrosis. We should also consider the possibility of tuberculosis, given the risk factors, and it's crucial to keep an eye out for any coexisting malignancies. Given the patient's history, a respiratory referral is a good idea if it hasn't already been made. And that wraps it up. If you found this breakdown helpful, don't forget to subscribe to Radiology Made Easy. Drop a comment if you've seen cases like this or if you have any burning questions. Let's keep learning together.